At the outset, I would like to thank Dr. Banshi Sabu, organizing committee, and Dr. Archana Sada and the colleagues from my pediatric interest group. Thank you, Chairperson, for the kind word. And definitely, I'll be speaking on Modi, which is ending with Y, not I. So, thank you, everyone, and welcome to the talk. So, as we all know, and we are going to see a lot of this slide in our schedule of this Diabetes India, that we are the diabetes capital of the world, and diabetes is rising exponentially, and around 10.1 crore people are there in India as per the ICMR data, and they are increasing exponentially. And what Dr. Meenal told, that diabetes in young prevalence is also rising exponentially, and it's a very worrying fact. And as rightly said, that it can be called as a malignant in younger people because it is more severely progressing disease and more chances of complications. So what we commonly see in young people is still type 1 and diabetes. However, because of the changing paradigm and increasing obesity in childhood, we are also seeing lots of type 2 diabetes. Few of them are having type 3C diabetes and MODY 2%, which is also still underdiagnosed and misdiagnosed as type 1 and type 2. So incidence may be even higher, 6.5 or 8%. Then severe insulin resistance and LADA is also seen in patients who are young. So monogenic diabetes is caused by a defect in a single gene, whereas MODY is the most common form of it. Other severe resistance syndromes and other syndromes like Downs and myotonic dystrophies and other genetic syndromes are also seen with monogenic diabetes. So we all are aware there are 14 subtypes, and establishing a molecular diagnosis is very important because if you see the 14 subtypes, the defect is also different and the treatment is also different. Where some of them like GCK MODY doesn't require treatment except in pregnancy. Some of them are sulfonylurea sensitive and some of them requires insulin as well and long-term monitoring. So prognosis and the future treatment is dependent on establishing a molecular diagnosis of MODY. So in 1977, Tattersall et al. Has first coined this term MODY, and they defined this criteria that age of onset less than 25 years, autosomal dominant inheritance with family history in at least two generations, there are no autoantibodies seen, and non-insulin dependent mild diabetes. However, it may differ in different subtypes. And with the changing paradigm of age of onset of MODY and de novo mutations being seen, now the criteria has been relaxed a bit and revised, where persistent hyperglycemia in early adulthood till the age of 35 years, clinical features which are incompatible with type 2 and type 1 DM, there is no autoimmunity seen, and diabetes in at least one first degree relatives is there. So these are the criteria which were little bit relaxed later on. So why it is important to identify MODY? Genetic defect is very important because it enables the recognition of phenotype and pathophysiology. And once you establish the correct molecular diagnosis, you avoid misdiagnosis as type 1 or type 2 DM. You may offer more accurate prognosis of risk of complications, may avoid stigma and limitation of employment opportunities, especially in cases of GCK MODY, may enable production of risk in relatives, including offsprings, and it can be cost effective when appropriately selected individuals are screened because genetic testing is the gold standard for diagnosis, but it is a costly affair. So it has to be used judiciously, may help predict the expected clinical course of the disease and guide the most appropriate management, including the pharmacological treatment in particular person with diabetes. Despite having all these criteria, there is no standardized algorithm for diagnosis of MODY, and almost 80 to 90% monogenic diabetic cases are not recognized and they are misdiagnosed as type 1 or type 2 diabetes. So to address this issue, the Exeter University, Mr. Shields and Associates tried to develop a mathematical calculator which can give the probability of diagnosis of MODY, and then the genetic testing can be advised to those selected patients. However, it was mainly for identifying a relevant mutation in genes HNF1A, 4A and GCK. So it was based mainly on the clinical feature, which was easy to put in an online calculator, and you can calculate a positive predictive value, which can give you a guideline regarding doing a genetic testing. So most of these clinical criteria have used absolute cutoffs, and absolute cutoffs may miss 50% of the MODI. So there are few criterias like Wells score for DVT or Bethesda guidelines for the non-polyposis colorectal cancer, and on these bases they try to develop a mathematical model for calculating the risk for MODI. So they compared the discriminative characteristics of type 1 and type 2 diabetic patients, which were the HbA1c level, parents with diabetes, being female, older age at diagnosis. And for type 2, they considered lower BMI, younger age at diagnosis, female sex, lower HbA1c, and parent with diabetes, whether they are treated with insulin or tablets. So this showed a good discrimination and low rate of misclassification and performed well on their trial. So using optimal cutoffs, the prediction model improved the sensitivity from 72% to 91% and the specificity from 91% to 94%. So this model gives you ease of use, and in the era of precision medicine, the model translated an online calculator app that helps clinician to decide whether we have to send this patient for genetic testing to confirm the diagnosis. So this is how the online calculator looks like. You have to fill in the simple 7 parameters: age at diagnosis, sex, currently treated with insulin or OHAs, time to insulin treatment, BMI, HbA1c, current age, and whether the parents are affected with diabetes or not. And you just have to push the button, calculate the probability, and this is how the result would be seen. And it is a very useful free online calculator available. So how do you predict? So age range is between 1 to 35 years of age. And if the patient is being treated with insulin, which happens most of the time because of the younger age of diagnosis, then even the probability greater than 10% justifies further testing for C-peptide and islet autoantibodies. And if they are negative and C-peptide is present, then you should go for genetic testing, because the long-term financial burdening and stigma of type 1 diabetes can be prevented if the patient has MODI, which is better treated if the molecular diagnosis is established. If the patient is non-insulin treated, then probability greater than 25% would suggest offering genetic testing. However, there are limitations of the MODI calculator. Presence of extra pancreatic features is ignored. Using the calculator at diagnosis doesn't work. Time to insulin is a key variable. Does not include autoantibodies. Not validated in non-Caucasians, particularly in high ethnicity group where there is high incidence of type 2 diabetes, like Indians. It has not been validated in our populations. It has been validated only in European populations. And diagnosed age more than 35 years, calculation may not be effective, because there are 20% of cases of MODI which can be diagnosed after 35 years of age. So we have to use MODI calculator along with the clinical features, the treatment, the family history, and other useful informations like birth weight, neonatal complications, glycosuria, and then all these parameters along with the MODI calculator, and then you can take a decision. And there are few more algorithms have been given, where if you see GCK MODI, there will be mild fasting hyperglycemia, then low HDL, low triglyceride, and high LDL in patients with HNF4A, arcade syndrome with HNF1B MODI, and high HDL is seen in HNF1A MODI. So these all clinical parameters we have to take into consideration along with the MODI calculators. So this was again assessed by in published article was published in Diabetes Care, where multi-ancestry or multi-ethnic people were included in this methodology, and in those patients with high ethnicity risk for type 2 diabetes, this did not work well. So it needs to be further validated. However, being a simple calculator, it can be utilized with other parameters. And since the time is short, I will go to the last slide. So MODI subtypes with variable age of onset, low penetrance, and atypical presentation may not fulfill the classical diagnostic criteria. And currently there is no concise or standardized diagnostic algorithm for diagnosis of MODI. Overall, the diagnosis of MODI requires a high index of suspicion, clinical assessment like age, sex, vital parameters, then BMI, then arthropometry, adipose tissue distribution. So all this clinical assessment, diabetes specific tests like C-peptides, autoantibodies, and lipid profile, as I said, low HDL, LDL, Sometimes the uric acid hyperuricemia is also seen in some subtypes of MODY. So these diabetes specific tests and other pathological tests are also important. And the gold standard is comprehensive genetic testing, which is next generational sequencing will give you the diagnosis. Thank you.